Uh, Very good afternoon. So, next few minutes, I'll be talking on another labor monitoring tools for the low resource settings countries. This study has been conducted in Bangladesh. So, before starting my presentations, I like to highlight about the tools. So maybe you already know, or who doesn't know, I will give a brief description of these tools. In 1994, WHO advocates they conducted a multi-country randomized control trial and found that when using the partograph uses when the woman is in childbirth process, that is in labor. So if this tools is used, there is a significant difference in cesarean sections, emergency cesarean section, stillbirth, and obstetric labor. So this recommendation came in 1994. But out of that, till now, all over the world, including Bangladesh, they are struggling to improve the user rate of the partograph. So this low user rate is very challenging because you know that in the low resource settings or the remote areas, doctors are not always available. So the midwives or paramedics are only there available, and they don't know that how to tackle this. So these tools can be very useful for them to tackle the situation. So there was in 2006 there was a global review by the Global Fistula Project why this tool is not using globally. Number one, it came out that poor knowledge on how to use partograph, non-availability of this partograph sheet, lack of uniform protocol. User consider this as a clerical assignment or jobs, and lack of support from the systems. So I will request you to bring keep this in your mind because the solutions we made based on this. But there was a global efforts after that to improve the user rate. As the paper partograph was not using, so there was efforts from WHO and JFIGO to turn it into electronic mediators or devices, and they did it through proposing to overcome some of the challenges related to the paper partograph, like help promote consistent and correct use of partograph, that is protocol, linking e-partograph with the labor protocol, like prompt clinical assessment, overcome gaps in staff knowledge. Introduction of technology brings interest to the users. But on the top of that, JFIGO and WHO failed to improve the user rate after their attempts. In Bangladesh is not an exception regarding the use of partograph. Their low user rate has been documented as below as 3%. There was a study from the 24 districts, and this study found that 80% midwives have knowledge on partograph, but more than half, they don't use the partograph. So there is a gap. So keeping this in mind, we developed design a study with the objectives to test the user rate of existing paper and electronic or digital partograph during labor monitoring process in selected district hospitals in Bangladesh, and also to explore the feasibility and acceptability of electronic partograph among health service providers in selected district hospitals in Bangladesh, and also to determine, to look at the barriers and the facilitating factors about of the introduction of electronic pathograph. So what we did when we introduced or designed the electronic pathograph, we kept in mind to overcome the barriers of the 5 barriers mentioned in the Global Fistula project, and we looked at those barriers carefully to overcome those. Like poor knowledge on how to use pathograph. So this was mitigated through conducting training, refreshers for the nurses and midwives by national and local experts. The lack of supply of paper pathograph. So this was basically replaced when electronic pathograph was there, even though when the project was conducted, we supplied both paper photographs for those facilities. Lack of uniform protocol. As electronic pathograph has an inbuilt protocol in its design, so this has also ensured the uniform protocol. Lack of supervision from the systems. The electronic pathograph allowed the authority like hospital super, head of the obstetric and the duty doctors for making an instant online query about the use of pathograph for conducted deliveries for any earlier periods. And resistance to the use of pathograph, this is also one of the barriers. We perform a study connected to the user of the pathograph with the professionals and administrators who have potential to dilute the resistance not to use these tools during the labor monitoring process. So, in any time, if the supervisors or the hospital administrators or the obstetrician, they make a query that how many delivery have been conducted and how many pathograph has been done, he can directly look at from his or her devices that how many pathograph was not performed, and he just or she just make a query, ask the concerning person why it was not happening. So this instant query, without going through further, make the this health system linkage. So we designed a mixed method study. So it was a both quality, quantitative design. We followed a prospective crossover design here. So we chose 2 district hospitals. Bangladesh has 64 districts. So we chose 2 district hospitals who are characteristically similar and was chosen with the consultation of the directors of the maternal health service of the country. The nurses who are posted or midwives who are posted of those hospitals were taken to use these photographs. It was 18 months study during sometimes of 2015 to 2016, the study conducted. Our initial primary objective was to improve the user rate. So we opted more than 50% will be user rate will be improved, and we calculated the sample size, and we found that for each phases 506 delivery moments will be needed for this study. We also conducted the quality studies. We conducted key informant interviews and in-depth interviews. Key informant interviews was done for hospital administrators, senior professors, and the doctors. And we conducted also the in-depth interviews for the clients or the omens, and also the providers who use this photograph. So for the quantity part, we use the analysis, proportion chi-square test and the logistic regressions, and quality analysis we did verbatim and thematic analysis. But in these presentations, I will only focus on the quantity part. So if you look at the study modality, how we designed this study. So in the beginning, you will look at the two district hospitals, and they're supposed to use the paper pantograph. We conducted the training for those two district hospitals, and we half of the study populations we allocated for each hospitals, and we randomly assigned one hospital for electronic pantograph and another hospital for paper pantograph. And after completing the initial phase, the crossover design, so the paper one became the electronic one, and electronic one became the paper one. So this was also one of the strength of this study, this crossover design. So I will describe about a brief the involvement of this project of mine. So I was the principal investigator. So it was actually format of our IRB forms we need to submit for each institutional review board for this type. So I was involved in research idea and concept, study design, protocol writing, and the acquired fund, responded to external reviewer comments, defending the IRB board, developing the data tools and collections, help to collections the data analysis, interpretation of the results, and also the manuscript development. We have also developed a manuscript. At the moment, it is under review on the PLOS ONE journal. So let's see some results from the quantitative part. So in the general characteristics, you will look at only the religions and the parity are the diverse from the two hospitals. They are significantly different, but at the end we found that that was not different. So in terms of improving the user rate, if you look at the one district hospital, that is Joshore, the electronic pantograph rate, it was 38%, and for the in other hospitals that was in 39%. So in both the hospitals, the electronic pantograph rate was higher. So I should say that it is much more than, it is around 13 times more than the existing pantograph rate in Bangladesh. So we also performed the logistic regressions, and we found for both the hospitals in the phase 1 and phase 2, it is 3 times and 15 times more than the user rate is than paper pantograph. We have adjusted this analysis with maternal age, parity, religion, gestational age, mother education, husband education, and fetal sex. We have observed also another outcome. It was not though a primary outcome. We found that there was reduction of the mode of delivery, like for the cesarean section. At the moment in Bangladesh, the population-based C-section rate is 33%. So it is much more higher than the WHO recommendation. WHO recommend 10 to 15% population-based C-section. So there was one concern for the country that how C-section rate can be reduced. So we observed from this study that if pantograph is ensured to use or improve the user rate, the C-section rate also goes down. So in this study, in hospital, the studies after June, you will look at the proportion of C-section has gone down, and also in this hospital, the same phenomena is observed. So this is last of my slide. So in conclusion, we can say that the electronic pantograph seems effective in increasing its user rate, has potential to decrease the C-section rate, and we can try to implement this pantograph other places following the implementation research. So this is the references I used in these presentations. So this is the investigator teams, and thanks for supporting me to present this study for Kyoto University and my university as well. Thank you.